and welcome to today's webinar, Current Status of Detecting Monoclonal Antibodies and Free Light Chains in Serum. I am Kaylee Bach of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots and brought to you by Sabia. To learn more, please visit sabia.com. Before we begin, I'd like to inform the audience that if you would like to enlarge the media player where you can see us now in that top left-hand corner, you can do so by hovering over that box and simply clicking on the enlarge button. Now, we encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation, but you may also submit any technical issues here as well if you have any trouble seeing or hearing the presentation. So with that, I'd like to now welcome our speaker, Dr. Matthias Orth, Director of Institute for Laboratory Medicine at Marian Hospital, Stuttgart, and lecturer, University of Heidelberg, Medical Faculty of Mannheim. Dr. Orth, thank you for joining us today. You may now begin your presentation.
Hello everybody, I'm Matthias Orth from Vincent von Paul Clinic in Stuttgart and Heidelberg University, and today we are talking about the current status of detecting monoclonal antibodies and free light chains in serum. Our concern is the diagnosis of multiple myeloma, and there are different classifications, and there have been some changes in the last years. So I will first start with an introduction to multiple myeloma and the related diseases. We all know the famous MGUS, the monoclonal gammopathy of unknown significance. It's a benign disease which rarely involves into multiple myeloma. We have a negative M gradient. We have very low number of plasma cells in bone marrow, and there are no other signs of multiple myeloma in serum, such as abnormal calcium values. We have a normal renal function, we have no anemia, and there are no bone lesions. Then we have the full diagnosis of multiple myeloma. It's a symptomatic disease which requires treatment, and the characteristics are this CREP. This is hypercalcemia. It's a creatinine clearance lower than normal. These are bone lesions visible on bone radiography or CT or PET scan. We have an anemia, and there is a high proportion of plasma cells. And a patient like this is shown on the right-hand side, and everybody can see that there are numerous bone lesions, and it's clear that this patient will also suffer from this high calcium in his serum, which damages also the kidneys. In these patients with multiple myeloma, we have a higher proportion of one of the three serum light chains also. And then there's a big challenge. We have many patients which are just between MGUS and multiple myeloma, and it's called smoldering multiple myeloma. It's pathological, and it will progress into multiple myeloma at a rather high rate. And these are the patients where we are not very sure how to proceed. We have the treatments in MGUS, which is in essentially all cases not a reason to treat. It's only watch and wait. And in myeloma, is no question that this is a disease which has to be treated rather aggressively. And for the patients between the smoldering myeloma, there are some where we do watch and wait, and others where we start treatment. And the new treatments in multiple myeloma are the reason why this disease came into our focus. Few decades ago, there were only very few treatment alternatives for multiple myeloma, such as steroids in the first-hand side and some rather unspecific chemotherapy. And in the last years, quite a few very positive and very aggressive. On one hand side means eliminating the myeloma cells and not so much damaging the patient's treatments were developed. Many of them employ monoclonal antibodies, bortezomib and daratumumab, a monoclonal antibody. We have the disease as a progress from MGUS over to smoldering myeloma into active myeloma, and we hope that the treatment we can offer to the patient will keep the patient on a relapse for rather, a remission for a rather long time. The treatments are rather complicated and rather costly, and so it's very important to detect the patients who need the treatment, and for the patients under treatment, it's very important to monitor the progress or the regress of the disease. And now the complications arise. When we are talking about multiple myeloma, we have patients which produce in their abnormal cells intact immunoglobulins and free light chains. This is majority in about 3/4 of the patients. We have some patients who secrete only intact immunoglobulins. This is about 10%. About 15% of the patients only secrete free light chains, and there are very few patients who do not secrete any abnormal plasma proteins. And this is the challenge when we use either immunoglobulins or free light chains for the detection of the disease. So we know that the way we use, whether we look for free light chains, will not detect some patients, and when we use only for intact immunoglobulins, we also will have a diagnosis failure in a few patients. So our topic today is the detection of multiple myeloma by free light chains assays, and when we employ this strategy, we will detect about 90% of the patients with multiple myeloma. What are the methods to detect free light chains or monoclonal antibodies in these patients? The oldest technique is the serum protein electrophoresis, and we are looking for this M gradient, monoclonal gradient. Then we can do some immunofixation, or the newer techniques is doing immunotyping in capillary electrophoresis from serum. Some people also do it from urine, and we'll come to this later on. Then traditionally there's done some quantification of immunoglobulins, such as IgG, IgA, and IgM in serum. And there's also in the focus in the last year the quantification of the free kappas and the free lambda light chains in serum, and very important, the calculation of the ratio between these both free light chains. What are the techniques we are employing? For serum protein electrophoresis, you all know it. This looks like a normal protein, serum protein electrophoresis, and when we get the patients with multiple myeloma, we have either an abnormal fraction or peak exogradient. This might also be an asymmetrical fraction. It might be a very high fraction, and such in these patients, I might call this like a typical high fraction with a co-migration. And there also can be a very low gamma globulin fraction if only monoclonal free light chains are present in this patient. Overall, the sensitivity of this technique is rather low. For the quantification of the monoclonal antibodies, one quantifies the M gradient, and this is also a rather raw method, and it only works when the patient also secretes immunoglobulins. If we have a patient who only secretes free light chains, it will fail, and so serum protein electrophoresis is not a method to detect the progression or regression of the disease. In immunofixation, the proteins from serum or from urine, such as Gladstone proteins, separated in the electric field. They're detected by specific antibodies, And the separation is done either by electrophoresis or capillary zone electrophoresis. And this shows an example of a normal sample, as you know it. And the first line it shows the normal serum electrophoresis, and then we have a rather unspecific polyclonal IgG, IgA, IgM, and kappa and lambda. And on the right-hand side, you will see a patient with monoclonal banding in IgG and in kappa, so it's a monoclonal IgG kappa. The challenge of immunofixation or immunotyping is that it's in some cases it's black and white, but in many cases we get some results which are not so clear, and getting the diagnosis of a monoclonal IgG kappa or IgG lambda to a patient will change the life of this patient. So we have to be very sure that the diagnosis is rather reliable. And it's very time-consuming in the lab, because we have to discuss about the results of this testing. Then also we do the quantification of the immunoglobulins. This is traditionally done by nephelometry, or nowadays in by tubidimetry. And in patients with multiple myeloma, they will either have an increase of the involved immunoglobulins, in particular with IgG, and they might also have a decrease of the non-involved immunoglobulins when there's when the abnormal plasma cells override all the other cells in the bone marrow. But this is also rather gross estimation of the tumor. Now it comes to the detection of free kappa and free lambda light chains. So the plasma cells either produce free kappa chains or lambda chains, and they have a rather complicated metabolism. So the production rate of kappa to lambda is about 2 to 1, but the kappas are monomeric and the lambdas are dimeric. So the filtration by the kidneys of the monomeric kappas is larger than of the dimeric lambdas, and so actually the resulting blood concentration is 1 to 2. It's just the opposite way. But you can see that the kidney function will will influence the concentration of kappa and lambda in the blood. And we also have seen that myeloma will lead to renal insufficiencies. So it's pretty tough to tell whether somebody got a bad kidney function because of myeloma, or he just has abnormal ratio of kappa and lambda because of his renal function deficiency. The reference range is an indicator for clonality. So if there is a normal production of free kappa and free lambda chains, the reference range of this ratio is about 0.37 to 1.4. And in patients with renal insufficiency, the kappa ratio is a bit higher, about 0.46 to 2.23. But this is rather a challenge, because renal insufficiency is not black and white. There are people with a severe impaired renal function, and there are many people with slightly impaired renal function. And when we employ different reference ranges, it's complicated to tell, shall I start with a GFR below 60 to use this renal insufficiency ratio, or shall I start with 40 or 45 or 35 and so on? Rather challenging. So, for example, if a patient either got kappa lambda ratio highly elevated with 8 or very low one with 0.6, they got either monoclonal kappas in this elevated case, or monoclonal lambda in this severely diminished ratio. The kidneys are very important in the metabolism of these free light chains. So under normal circumstances, we have a half-life time of about 2 to 4 hours of the free light change. They are completely glomerulary filtrated, but they're metabolized in the proximal tubuli. And in normal healthy subjects, these free light chains are not detectable in the urine. So they are excreted only in so low concentrations that it's hard to tell that they're present. The typical production is something about half a gram to 1 gram per day, but this production can, or the metabolism by the kidneys can increase up to 30 grams per day. So if my production of free light chains is elevated 25 times, I will still not show up free light chains in my urine. So I can have like a massive increase in production of free light chains without any light chain showing up in the kidneys. If this stays on for a longer time and my kidneys are damaged by the multiple myeloma, then the urine will also show up the free light chains. But the free light change in the early stages of multiple myeloma in the urine are not useful for detecting the disease. So this abnormal free light change, they can not only be present in multiple myeloma, but also in patients under immunosuppression or under immunostimulation, or when the renal function is diminished. In this case, both kappas and lambdas will be increased, and therefore they will have a rather normal kappa to lambda ratio. When there are monoclonal plasma cells, then only one of these free light chains will be increased, and therefore we will have an abnormal kappa to lambda ratio. Now it comes to the detection of these free light chains. We have seen the other methods of detecting the proteins present in multiple myeloma patients. This is traditional protein chemistry, in which case mostly we stain the abnormal proteins. But for the detection of free light chains, we need special antibodies which detect a certain part of the protein which is not accessible to antibodies in the intact immunoglobulin. And this is this so-called hidden surface. In the intact protein, the areas with the places where this arrow goes there, the antibody for the detection cannot bind. But when we have the free light chain, then this previously hidden surface becomes accessible, and the antibodies will bind and can be quantified. How is this quantification of these free light chains done? Essentially, there are two techniques. One is like done in tube, either by nephelometry or by tubidimetry, and the other technique is in the microtiter plate, quantified by ELISA. Many tests are done on this turbidimetry assays because they can be simply automated, can be done by random access analyzers, and but the testing these samples in ELISA plate format also has advantages. It also can be automated, and there are few advantages such as no antigen excess issues. There's not such an overestimation of polymerized samples such as in this turbidimetry and nephelometry assays. We need fewer dilutions. I will come to this later on, and there is a good linearity with the dilutions. The challenge is in particular with the kind of proteins. When I have for example, if I want to quantify albumin, which is a rather simple, very well-defined protein, and I do this by turbidimetry, this is the perfect way to do. There are very few issues which interfere with the detection of the protein. But this abnormal light change detecting by turbidimetry is a huge challenge. We are talking about abnormal proteins, and these abnormal proteins do everything which we don't like in protein chemistry. So I will start with the middle. Is this very high degree of polymerization, So we also have seen that the issues in kappa and lambda with dimers and monomers, and if we have abnormal proteins, we can have like trimers and pentamers and so on. And it's nearly impossible to predict the signal in nephelometry or turbidimetry when you got a dimerized or polymerized protein compared to a monomer. The other issue arises with the lot-to-lot variation. In this light change testing, we are using proteins. Most of the assays employ polyclonal proteins, and it is a challenge to keep the lots comparable. We are talking about a disease which progresses over many years, and even when we have a small batch-to-batch variation, this can come up with huge differences over the years. Then we have the assay imprecision, which is we're talking about often very small concentrations of a protein, which is very difficult to measure. Then we have the problem that many of the dilutions are non-linear. It's a particular problem with kappa. Then we have the issues with antigen excess. I will come to this in a minute. We know that we have abnormal proteins, and there might be hidden epitopes, changed amino acids, so that the antibodies we're using might not match the antibodies in a certain patient. And there's still the issues of some cross-reactivity with intact immunoglobulins. We have to know that most light change are bound to intact immunoglobulins, and that when we have like a cross-reactivity of 1% of the free light chain assay with intact immunoglobulins, this assay would be useless, because then it would only show the intact immunoglobulins. So we need a very, very, very low cross-reactivity, which so that the reagents are useful. This strange proteins is also seen in patients. So we have this. We are dealing as clinical pathologists in the lab with this misfolded proteins only in our serum, like in our cuvettes and tubes. But in fact, we have patients with amyloidosis, and these patients suffer from this misfolded proteins. This what is going on in our samples submitted to the lab. It also goes on in the patients, and we have the deposition of these fibrils, these abnormal proteins, such as in the eye, in the tongue, in the nails, in the soft tissue, or the worst thing, in the heart. So this is not something which is an artifact in the lab, which is also, like in patients with amyloidosis, very present. And we know how difficult it is to treat these patients. So I have talked about the high-dose hook effect. This particular concern in nephelometry or turbidimetry. This means in normal assays, the antibodies we are using as a reagent must be in excess over the antigen. But when we have an analyte, such as the free kappa or free lambda, which can be present in very low concentration and very high concentration, the reagent has to cover the whole range of patient results, and this is not feasible. So we are doing a test, and in fact, the antibodies we are using are not sufficient to detect all antigens. And so we got a certain result, such as here with 10 to 5, and the result is identical to 10 to the 8. So we have to do a dilution afterwards and have to check whether the diluted sample gets a realistic result. So this means that in essentially all samples, we have to do a minimum of 2 dilutions to get a result which we can trust. And this comes to the optimized scheme how to dilute the samples. It's the measurement range of the assay, and the result. And this measurement range is a bit different from nephelometry or turbidimetry compared to ELISA. So in ELISA, the measurement range is wider than in turbidimetry. It's also very important that the reporting range is within the reference range. it does not make sense when the assay says kappa is below, let's say, 10 milligrams per liter, because then we cannot tell whether it's a suppression of kappa or whether it's just a normal result. So we have to make the dilution in that way that a result within the reference range is possible. We want a fewest number of dilutions, and if possible, we don't want too many dilutions afterwards. So this is a particular concern in ELISA testing, where we can't repeat the sample within the same minute. We have to do it for the next batch. And we also want only very few samples too low or too high. So we played around with the Xavier testing, and Xavier suggested dilutions of 1 to 1,000 and 1 to 10,000. And our optimized dilution was 1 to 5,000. And we get the first result in more than 99.4% kappa, for example. Then we did some comparisons of this ELISA tests with binding site assay done on stoichiometry, and the comparison was not so good. But when you compare this with other tests, the results are pretty similar. So the correlation of the different free light chain assays is lower than we know, for example, from enzymes and maybe from other proteins. And it also makes sense because the proteins in many cases are so abnormal that they cannot react the same way with antibodies. So, for example, here I show you a comparison of binding site, and in one case we even got a patient with proven multiple myeloma, and with binding site the patient got excess of kappa with 308 and with lambda with 43, and in Xavier it was just the other way around. So there was only a kappa of 45 and a lambda of 203, and we repeated this with both assays several times, and it came out the same way. So this also has been shown in other assays that even the proteins can be so abnormal that it's hard to tell whether it's a kappa or it's a lambda. This is the comparison of from literature comparing binding site with Siemens monoclonal assay, and you also can see that there are huge differences between both assays. So it's pretty much the same data as I showed you from our data. The next challenge is to get the correct reference range for this test. Our experience, the reference ranges given were by far too low. So we flagged too many patients. And this is also logic because the reference ranges are found in young patients with normal renal function, and our testing was performed in older patients, most of them with impaired renal function. And so we employed an indirect method. So essentially this indirect method uses normal patient data and tries to differentiate patients with normal values from patients with abnormal values. And in this case, for the Xavier test, the difference was for kappa by 64 milligrams per liter, and it was for the lambda was for 40 milligrams per liter as the differentiation between abnormal and normal results. This is much higher than the numbers given from the literature. This whole thing did not work for binding site assay because the measured range, too many dilutions, was too high. So this does not work in this case. But when we compare this, I think this is rather nice data. We found the reference range of the kappa of the Xavier assay and the binding site assay to be very similar. So it was like for the kappa assay in Xavier, it was from 10.6 to 64.6, and for binding site from 3.7 to 67.8. For lambda had 8.4 to 40 or 4 to 42. And on the right-hand side, you can see the recommended reference ranges, which are much lower for both cases. The interesting thing is when we go for the ratio, the kappa lambda ratio, from the insert, it says 0.37 to 1.44, and when we do the indirect method, it comes to 0.35 to 1.43, so this is essentially identical. So this shows that with the indirect method, we get much higher reference ranges for the population which is tested for free light change, and but the ratio is nearly identical. So, and we use the same reference ranges for kappa, for binding site and Sabia, and we use our data which we got from this indirect method, and with this, using these reference ranges, the proportion of patients flagged was rather low. Beforehand, it was, I think, like something like 60 or 70% of the patients were flagged with abnormal results. So I want to summarize the testing for free light chains. The serum method should be used to detect these monoclonal antibodies respective to free light chains in multiple myeloma patients. The key test is the quantification of the free light chains, and especially the kappa to lambda ratio. It's used for diagnosing and monitoring these clonal free light chains. Serum protein electrophoresis is used for the detection and quantification of the M gradient. It can be used for monitoring progression in case there's an M gradient in the beginning. Immunofixation or immunotyping is used for the classification, and it's only used for diagnosis, and there's no need for monitoring. The quantification of total IgG, A and M can be done supplementary, and at the current stage, the testing urine is only an add-on. Urine free light chains is without use for monitoring. Thank you for attention, and I'm happy to take your questions.
All right. Well, thank you so much, Dr. Orth, for your very informative presentation. We will now start the live Q&A portion of the webinar. So if you have a question that you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left-hand side of your screen, and we'll answer as many of your questions as we have time for. All right, so let's get started. Dr. Orth, we've got some great questions coming in here from our audience. So I'm going to start with this one. It asks, do you have any recommendations on the number of duplicate patient samples that should be run when considering switching from one SFLC vendor to another?
That's a good question. I think the problem is how confident you are in the new results and how good you can transfer this to your oncologist or nephrologist. So I think you have to do some duplicate testing for, let's say, for 3 to 6 months. And so you feel comfortable that you have seen most of the patients with the old assay and with the new assay. So it depends on the workload you have. So I think you have to run a few thousand samples in parallel when you switch. Yeah.
Perfect. Thank you so much. All right. Another question here. What was the impact on your lab in implementing Sabia's SFLC assay, such as training, workflow, tech implant, or impact, etc.?
It's a matter of integrating the protein chemistry into your lab. The problem is when you do the binding site assay, you should do it on a binding site analyzer. But you're only having one analyzer for one test, so which is not really fun to do in the lab. So you're trying to integrate the binding site assays to another analyzer, such running on the cobars or we did on the image. But then you have the problem that this analyzer is not really supported by binding site. So it's a lot of hassle for a single test. So when we switch over to ELISA testing, which runs on an automated system, bidirectional, so essentially it's easier to run it as an ELISA technique instead of doing like with nephelometry or turbidimetry. So I think the technician liked it to do the testing on the sepia ELISA. The other point is doing the dilutions. This is you have to be confident that the result you're reporting is correct. And when you do monitoring of the patients, then you can see discrepant values. But when you do it for diagnosing, you have no hint whether the result you're reporting is correct. And so if you have an assay which comes up with some implausible results and you're just repeating the results, this is not a nice situation. So it's better to switch to an assay which you are more confident. Yeah, this was the point with getting like 99% of samples right in the first run. It's very good for the atmosphere in the lab and the confidence into this assay. Yeah, doing the repeat dilutions, it's a pain, especially when you go to manual dilutions. Then you got like errors and typos and all this stuff. This is not fun. Yeah.
Great, thank you, Dr. Orth. Like I said, we've got some great questions coming into the studio here, so we're going to continue. This next one asks, how did your lab discover some of the limitations of your previous SFLC testing method?
I think the problem pretty much occurred with this support of binding site or discontinuation of their instrument. So if normally I want to have the vendor of the instrument and the vendor of the reagents be in charge that I get the result in the correct way. But when I buy a reagent and then the vendor tells me, oh, this is kind of an LDT and I do not care about the results, then I'm in trouble. And this was the point when you were switching the reagents from binding site to another instrument from another vendor. And so I'm much more confident to have like a reliable testing platform, such as ELISA testing, which is no concern where you run it. Yes. Yeah.
Great, thank you. All right, our next question asks, how did Sabia define the renal insufficiency population to be able to publish a different reference range? I assume this information is available in the package insert, but please advise.
Yes, this is a problem. It's a huge problem. Like there was a very nice paper in very recently in the June issue of ACC from Washington University dealing about this identical issue. About 50% of our patients have renal insufficiencies. They have like a GFR below 60. So nearly the majority of our patients do not have normal renal function. And some of them, they got like renal function of 59 milliliters per minute. And some with the normal renal function, they got like 61. You know, it's not black and white with renal function. It's just a continuum. And it pretty much depends on the patients you're testing. Like our focus is on patient with like a creatinine of, let's say, 2 milligrams per deciliter, and they are tested for multiple myeloma. So they already have renal insufficiencies. And so I can't say renal insufficiency is present or not present. It's a continuum of severe renal insufficiency and so on. And therefore, I'm not confident with this two different reference ranges which are reported by Sabia for the renal insufficiency. You have to look on your own study population whether you're only liking with slightly impaired renal insufficiency or severely impaired renal insufficiency. It's a very complicated issue. But the normal reference ranges were obtained from 2 healthy persons. This is the problem. Nobody is going to test 20-year-olds for multiple myeloma. And normally you're testing 60-year-olds or 70-year-olds, and essentially all of them have some slightly impaired renal function. Yes.
Great, thank you. All right, next question here asks, how significant is the quantitative kappa to lambda ratio in detecting and evaluating FLC monoclonal antibodies if both kappa and lambda concentrations are elevated?
Yeah, this is the problem with getting the right reference range for the concentration. Like normally you do the diagnosis with the ratio. So if you got a too high or too low ratio, then you can say the diagnosis. I won't go for a ratio of 100 or 0.01 because this is only very rarely seen, and essentially all patients with multiple myeloma don't have a ratio above 100 or below 0.01. But you don't want to do the ratio in normal concentrations. And this is the problem when you use the old reference ranges. Essentially, whatever 80% of the patients will have elevated concentrations, and then you do the calculations, and there might show up some abnormal ratios. And therefore, I recommend to use extended reference ranges for the concentration, and only when the concentration is elevated or too low, then do the calculation. Yeah. So this is, it's about, otherwise when you use the old reference ranges which are too narrow, you're having too many positives, and you get too many false positives even with the ratios.
Great. Well, thank you so much for that answer. We have time for some more questions here. So we'll continue. This next one asks, does your lab run serum protein electrophoresis and SFLC as a screening panel for patients with suspected monoclonal gammopathies in alignment with the recent CAP guideline recommendations?
Yeah, that's a good question. So I think we have like two types of patients we are testing. Type one, they're from like internal medicine, oncology. They do the screening with serum protein electrophoresis. And then we have the patients with the impaired renal functions, and they will never do the serum protein electrophoresis for screening. They start with the FLC. And this is in accordance with the European recommendations for the guidelines. They say, even when there is no M gradient, you can do the FLC testing for screening when you have some high chance that the patient got myeloma. And I think in these cases, when there is already impaired renal function, there are some chances that there's multiple myeloma, the reason for this impaired renal function.
Great. Now, Dr. Orth, what could be a possible reason for kappa and lambda results not matching with protein electrophoresis?
I think it's a matter of how much immunoglobulins you have. The FLC is testing free light chains, and this is not totally related to the immunoglobulins. You might have high secretion of free light chains and no immunoglobulins secreted, or only very low concentrations of of complete immunoglobulin secreted. So I think this is not a problem. It's just we're talking about tumor cells. They don't behave like normal cells, and some they like secreting only the free light chains, and other they secreting mainly intact immunoglobulins. Yeah.
Great. Now, do you have any comments on the heavy light assays, utility, or any plans on CDF?
No, essentially I don't have experience, and I think like it's a matter of how many samples you obtain. And like in our lab, I tried. We have this is very esoteric, so we only have like a handful of requests for this. So and therefore I didn't take too much time to introduce this in my lab. I think this is something for a reference lab, and then they should try to get the best test on the market. But I have no experience with this. Yes.
Great, thank you. Another question here for you. Is there a purpose for testing the serum IFE monthly, and how often should an IFE be performed on a patient?
I think IFE monthly is too frequent. Like normally we go like for a minimum of 3 months to 6 months distance between testing. It's in my experience, it's a matter that in very few cases you have a very rapid progress, but in most cases, the disease is not progressing so rapidly, and I would not ask the patient to show up in 4 weeks again. Yeah.
Great, thank you. When transitioning, should results old and new be reported together for a short time, or do we tell providers they need to establish new baseline when changing assays?
Yeah, that's a good question. I think that if somebody is in relapse, so some of the treatments are really excellent, and now you can really treat patients. So if it's a very successful treatment, there's no reason to keep the old assay running for years. So if there are no free light chains present with any assay, then you can just use the new assay to proceed. Yeah, for the exclusion of a test, you start with one assay and there's no reason to repeat the testing anyways. It's just for the patients which are not under good regress. So they show up the disease, and there you have to run the test in parallel. So I think you should have both assays available in the lab for, let's say, minimum of 3 to 6 months. Or maybe after that, you might send the few patients. There will be only very few patients which need the parallel reporting to another lab who runs the other assay. So there's no reason to keep the old assay running for years. I think this is too much.
Great, thank you. Now, do you use the 1 to 5,000 ratio for lambda as well? And how high is the retest rate for lambda?
This was when I get this right, the dilution it's the same dilution. Yeah, and the retest rates, they were pretty similar for kappa and for lambda. So there's only one dilution for both for kappa and for lambda. Yes. Yeah.
Great. And is there a difference in running FLC kappa lambda manual versus automated?
We've only done this on the automate. We are not doing this manual ELISAs because I think it's you have to do the dilutions, and you have some repeats and so on. And you have quite a large number of samples, and I don't want to get this messed up. So it's not like in when you, for example, if virus serology, where everything is positive or everything is negative, you only got like one sample of concern. But in this case, each single patient is very important. And I'm not so confident if a technician has to run like 50 samples with manual dilutions. So the chances that there's a mix-up is too high. So I would always go for an automate. Yes.
Great. Well, Dr. Orth, we have time for one more question here today, so we'll wrap up after this one. Do you feel there is any merit to the recent publications of concern that as a population, the kappa and ratio ranges should be higher than 1.44?
Yeah, this is the problem, that the reference ranges were obtained in renal normal patients, like in healthy patients, and the reference range should kind of be obtained from a population which is similar to the patients you're looking at. And so therefore, I think the lambda reference ranges, they fit quite well, but I think the biggest concern is this kappa, and the kappa is by far too low, because essentially all patients we do the testing have some renal impairment. I think this is just a very simple explanation for the too low kappa values in the old reference range, and so there has to be an adjustment of this kappa. Yes. Okay.
Great. Well, Dr. Orth, I want to thank you again for your time today and your important research. We would also like to thank Labroots and our sponsor, Sabia, for underwriting today's educational webcast. But before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.
Okay. Thank you.